It's forming in the most critical, most delicate part of the entire lung, that alveo-capillary membrane, where all the magic of gas exchange actually happens. This scarring makes the lungs stiff. It makes them thick, and that's exactly why these patients come in with that classic progressive shortness of breath. You cannot just order a chest CT. A standard CT scan uses these thick slices of imaging that will completely, totally miss the subtle early findings of interstitial disease. You must specifically order a high-resolution CT. This is the classic textbook finding, honeycombing. And the name is perfect. It's so descriptive. You can actually see these stacked little cystic air spaces with these thick fibrotic walls. It looks just like a honeycomb. Now, this isn't an early finding. This represents advanced irreversible scarring. When you see this pattern, especially down in the lower lobes of the lungs, IPF needs to be right at the very top of your differential diagnosis. Idiopathic literally means we don't know the cause. IPF is what we call a diagnosis of exclusion. HP, on the other hand, is an immune reaction to something the patient is inhaling. This could be antigens from birds, that's the classic bird fancier's lung, or maybe it's mold from a contaminated humidifier or air conditioner. And this is critical because for HP, the #1 treatment is finding and getting rid of that exposure. An acute exposure causes a ton of inflammation, which on a CT looks like these hazy ground glass opacities. Over time, you get this mix of inflammation and fibrosis, which creates this classic mosaic pattern with air trapping. But after years and years of chronic, low-level exposure, the inflammation can kind of burn itself out, leaving only scar tissue, and it can look almost identical to IPF, complete with honeycombing. On an imaging study, you might see these telltale pleural plaques. These are calcifications on the lining of the lung, which are pretty much a dead giveaway for asbestos exposure. HRCT comes back, and it shows these diffuse, tiny 2 to 3 millimeter nodules just scattered all over both lungs. What occupational disease should be on your differential, and what major infection does it famously mimic? The answer is silicosis. Exposure to silica dust, from mining or quarrying or sandblasting, causes this pattern of just countless tiny nodules. The problem is, this can look identical to miliary tuberculosis. You might accidentally treat a patient with steroids for what you think is an inflammatory lung disease when they actually need powerful antibiotics for a really life-threatening infection.
You've got small airway disease, that's the chronic bronchitis part, and you've got destruction of the lung tissue itself, which is the emphysema. You see those veins pop out when they breathe out because the pressure inside their chest is so high from trying to force air through tiny obstructed airways. And hey, if you see clubbing, that's not typical for just COPD. It should make you start thinking about other things going on like bronchiectasis or even a lung cancer. If your COPD patient starts getting sleepy, do not, I repeat, do not just assume they're tired. You have to assume they are retaining a ton of carbon dioxide. We call that hypercapnia, and it's causing CO2 and narcosis. This is a sign that they are on the verge of stopping breathing altogether. But in a bad COPD flare, they often develop type 2 failure. This isn't just an oxygen problem, it's a ventilation problem. They physically can't get the CO2 out. See, in you and me, the strongest signal telling our brain to take a breath is rising CO2. It's a powerful alarm. But in patients who have chronically high CO2, their brain basically gets used to it. It puts the alarm on mute. So the body switches to its backup system, low oxygen. Hypoxia becomes the new alarm telling them to breathe. So what do you think happens if we come in and just blast them with 100% oxygen? We turn off their only remaining alarm. We take away their drive to breathe, and that can be catastrophic. It's one of the few times in medicine where giving too much of a good thing can be incredibly dangerous.
When we're managing these patients in the clinic, we use something called the GOLD classification. It helps us group patients based on two things: how bad their symptoms are day to day and how often they have exacerbations. A patient in Group A, for example, has pretty mild symptoms and doesn't get sick often. But a patient down in Group D is very symptomatic and is in and out of a hospital. It literally tells you which inhalers to prescribe. It's all about matching how aggressive our therapy is to how severe their disease is.
Your goal is not to get their oxygen saturation to 100%. In fact, trying to do that is dangerous. Instead, we aim for what's called permissive hypoxemia. Your target is an oxygen saturation of 88 to 92%. That's the sweet spot. It's enough oxygen to keep their vital organs happy, but it's low enough that you won't switch off their hypoxic drive to breathe.
You're looking at a chest CT. It can be kind of disorienting trying to figure out where you are. Just remember this. If you can see the carina, that's the spot where the trachea splits into two, you are looking at a slice through the upper lobes of the lungs. If you scroll down, and the heart is the big thing in the middle of the screen, you're in the lower lobes.
It's really important to know that for some of those diseases like IPF, getting a diagnosis is a whole different ballgame. A little needle biopsy is totally useless. The pathologist needs to see the big picture, the architecture of the lung. And for that, you need a surgical lung biopsy, which is a major procedure. A spacer isn't just about making the inhaler easier to use. It's a safety device. It's a big deal. See, when you use an inhaled steroid, some of the larger drug particles, they just smash into the back of the throat instead of getting down into the lungs. Well, that steroid sitting there creates the perfect breeding ground for a fungal infection, oral candidiasis, or what we call thrush. The spacer physically traps those big particles, which stops this common and frankly really unpleasant side effect from happening.
A dry powder inhaler, like an aerolyzer. This device is a whole different ballgame. It relies 100% on the patient's own effort. They have to take a really deep, really fast breath to pull that powder out and get it into their lungs. So you have to think critically here. Who can't do that? Well, young kids for sure, frail patients, and most importantly, anyone who's in the middle of a severe asthma attack.
Last but not least, the nebulizer. You've all seen these. It turns liquid medicine into a fine mist. The big advantage? It requires zero patient coordination, which is great. But it comes with its own risks. That little chamber can become a breeding ground for bacteria if it's not kept dry. 2 puffs from an MDI, used correctly with a spacer, is just as effective as 1 full nebulizer treatment. Oral agents? Nope. They cause systemic side effects that we can totally avoid by just using inhaled therapy. IV beta agonists? Also no. They carry risks like arrhythmias and don't really offer much benefit over the inhaled versions. And theophylline? This one has a super narrow therapeutic index. That means the line between a helpful dose and a toxic dose is razor thin.
Pulsus paradoxus. So what's happening here? Well, during a really bad asthma attack, the pressure swings inside the chest are just massive. When the patient inspires, the negative pressure is so intense that it actually pulls the intraventricular septum over and gets in the way of the left ventricle filling up properly. And what's the result? You get a big, palpable drop in systolic blood pressure when they breathe in. If you find this, it is a major red flag that your patient is in severe distress and is working way too hard to breathe.
The patient is confused, they've clearly stopped fighting to breathe, and when you listen, their chest is silent. Based on everything we've just covered, what is your immediate next step?
Back up, that traffic jam, that's hypoxemia. That's why your patient can't breathe. It all comes back to the shape of these cells. Now, before the air even gets to those alveoli, it has to travel through what we call the small airways. And that number, less than 2 millimeters, is so important. Why? Well, think about your main windpipe, the trachea. It's held open by these big, strong rings of cartilage. But these little guys, they have none of that. They're just soft tissue. That makes them incredibly easy to squeeze shut with just a little bit of inflammation or mucus. And that, right there, is the fundamental problem in diseases like asthma and COPD. Someone with severe COPD is trapping a ton of air. To force that air out, they have to generate massive pressure inside their chest. That pressure squeezes the big veins and makes the neck veins pop out, but only when they're breathing out. Now, contrast that with heart failure. That's a state of constant fluid overload. The pressure is always high, so the veins are going to be bulging on inhalation and exhalation. Plain, uncomplicated COPD does not cause clubbing. It's a red flag. It's a giant alarm bell telling you to dig deeper. Is there an underlying bronchiectasis? Is there a hidden lung cancer? Is there interstitial lung disease? It's a two-pronged attack that has to treat the whole person. Pulmonary rehab is non-negotiable. It's basically physical therapy for breathing, and it works wonders for improving function. But you can't ignore the mind. Imagine the constant anxiety of never feeling like you can get enough air, the depression, the isolation. That's why psychotherapy, support groups, and mental health care are just as crucial as any medication we can prescribe.